other. And so Dr. Killewich comes to us. She was raised in Juneau, Alaska, and then she came to the lower 48, and then went to Pacific, sorry, I always get that one, University of the Pacific for college. Then she went on and did some work back in Alaska for a few years, and then went on to get her PhD in biochemistry at Columbia. And then went to medical school at the University of Washington and studied with Gene Strandis, who, if anybody knows, he's sort of the forefather of the non-invasive vascular laboratory, and really made great strides in all of that. Then went on to do her general surgery residency at UC Davis, where she worked with Dr. Blaisdell, Dr. Blaisdell, and then went on to do her peripheral vascular fellowship in St. Louis. Then went on to University of Maryland, where she was chief of the VA in vascular surgery there, and then came down to Galveston. And interestingly enough, she came in 1999 when I left to go do my vascular fellowship, and then came back. So then we got to work together as colleagues. So she never did train me, per se. Anyway, she's very well published in DVT and muscle metabolism, over 50 publications. She now is on the road with the TMA, giving lots of talks for various things, and has come out here to San Antonio to give our talk today for current challenges for women surgeons.
Well, good morning, everybody. Obviously, for me, it's really an honor to be here today. Lori and I worked together for 6 years, and I have to say that although I did sort of act as her mentor during that period of time, I certainly learned as much from her as she did from me, and can tell you that you guys are very lucky to have her here. So, today's topic is current challenges of women surgeons, and just a couple things I'd like to say right off the bat. It is certainly not my intention to alienate half of the audience who happen to be males. So, of course, present company is always excluded. I've tried very hard in the things that I'm going to present to use only data that is published in the literature. It's not, some sort of wild thing that I thought up on my own. And I'd also just like to remind everyone that either you are a woman or you probably have a woman who's very important in your life. Could be your spouse, your partner, and more commonly nowadays, many of the men will have daughters who are going into medicine and into surgery. So, with that introduction, we'll move along. These are the objectives for my talk: to discuss factors that contribute to what's called role strain for women surgeons, to discuss the behaviors consistent with gender discrimination and sexual harassment, and finally to review some potential solutions. I should also say I have no disclosures. So we're going to begin with a quote from a male physician in the early 1900s. This physician said, "Physicians have often been agitated by the demands of women to be admitted to the practice of medicine. It cannot be denied that feminine mental faculties suffice for the acquisition of medicine. On the other hand, only a few girls will take up the study, and these few will be those who are not really fitted for maternal duty. Thus, medicine, like the women, will not derive much benefit from these efforts. It will not amount to much." Well, times have changed. Here's a graph of the percentage of women who are currently in medical, well, actually over the last 40 years, who have entered medical school and who are practicing physicians. And what you can see here is that back in the 1970s, there were about 20% of medical school applicants who were females and really less than 10% practicing physicians. Now, the curves, of course, go up. And so by 2008, when this data ended, about half of the students entering medical school are female, and about a third of the practicing physicians in the United States are female. So first thing we're going to do is talk about what's called role strain. So here's the definition of role strain. It is conflict experienced when managing and fulfilling competing but fluctuating role obligations. Probably something that everyone in this room experiences. You're a parent, you're a partner, you have a career, so on and so forth. So what is it about women that leads to particular issues with regard to role strain? Well, we as women tend to fulfill a lot of different roles, obviously. So we are doctors. Some of you will recognize this person here. We are mothers. That's Lori. We are also wives. That's my husband and I taking a hike in Zion National Park a couple years ago. And then we are also daughters. And of course, for those of us who are baby boomers, and I happen to be a baby boomer, if you all know what that means, we now have parents who are entering an age where they require care. So again, we fulfill a large number of different roles. So what about those family responsibilities? Well, compared to male physicians, female physicians do tend to traditionally take on more role responsibilities. And so if you look in the literature, you will find that female physicians experience more conflict between their career and their family. They tend to perform more household duties and more child care, and also have more responsibility for other dependents like their parents. The statistics at the bottom of the page, these are taken from a survey study which was sent out to about 1,000 pediatricians. And what it found was that if you looked at child care, 66% of the female pediatricians reported that they were involved in child care activities, whereas only 26% of the males. And 63% of the females were involved in household activities, but only about 20% of the males. Then there's the issue of pregnancy and motherhood, and this is something that certainly has changed since the time that I was a resident. I was a resident back in the early or mid-1980s, and at that time, really, it was just not considered appropriate to have a child while you were a resident. When I was a junior faculty at Maryland in the 1990s, times had changed, and a lot of the residents were having children during their research year. And now, of course, in the 2000s, residents are having children when it seems appropriate for them to do so, and I applaud them. But in any event, again, back when I was training, really the question wasn't so much when to have children, but should I have children? And I actually do not have any children. And I do credit that to the fact that during the years that I would have been having them, I was so heavily involved in my career I didn't have a chance or didn't get around to it. In any event, if you look now, there are still about 1/4 of female practicing physicians who do not have children, whereas in terms of the male physicians, it's only about 10%. Also, in the same study published in 2000, 85% of the female physicians who were surveyed said that they had made a career change for their children, whereas only about 35% of men did that. And Lori related to me recently a story about one of the women who is currently a department chair in surgery in the United States and was asked to look at a deanship at an institution and decided that because of her child having adjusted to where she was currently the department chair, she was not going to move. Now, then there's the question of when I should have children, and we touched on that a little bit already. Needless to say, the best time biologically is also the time when the career demands are highest, and so that's when you're a medical student, a resident, or in your fellowship. Now, again, it doesn't seem to be the same issue that it was back when I was in that period of training, but it does follow that the best time biologically is also the worst time in terms of one's career. In this particular article that I'm quoting here, the worst times in terms of career demands were the 3rd year of medical school and internship, and I think that goes without saying that those are the 2 years when there is the steepest learning curve and the most responsibilities. And finally, the most common time these days seems to be residency. Now, of course, that does sometimes involve some resentment from your colleagues. And so, again, it's very important to try to get those things worked out so that you have the time that you need. So that brings us to the topic of maternity leave. The American College of Physicians recommends that maternity leave should begin at least 2 weeks prior to your due date, and that one parent should be the primary caregiver for the child for at least 4 months. So I won't ask for a show of hands, but in general, that doesn't seem to be what happens. In the United States, of course, as you probably all know, you are allowed 6 weeks of maternity leave and an optional 12 weeks of FMLA. But again, that doesn't seem to be the amount of time that most of us in medicine are taking. The study I've quoted here does go back as far as the 1970s, but if you look at medical school graduates in this study, about half took 7 to 8 weeks, but beyond that, there was almost no one who took the full 4 months. Of residents, 63% took less than 10 weeks, and interestingly enough, it actually went down when it came to the practicing physicians. So only about 50% or 56% took less than 6 weeks. Now, another thing that's important is, of course, to have a supportive partner, whether that be your spouse, your partner, your significant other, possibly your pet. And here I just put a couple of quotes. The top one is from someone who would be considered quite supportive. She quotes, "He is supportive in general. At the time when I call and say, you have to be home in 5 minutes, I'm not going to be able to pick the kids up, he always comes." So contrast that with the quote at the bottom from another woman who is a physician. "Because my mother had always worked and we had housekeepers come in, I didn't have the feeling that I have to do it all, that I have to cook dinner and have to make sure the house is clean. But he, the spouse, came from a family where his mother did everything and was a wonderful mother and always cooked wonderful meals. She was always around, and my husband was the one who constantly showered me with guilt that I wasn't doing that. I think he was quite unconscious of it, that he was the one putting the role on me more than I was. So I can tell you that when I was in Maryland in my first marriage, I was married to another physician, and I certainly felt that I needed to be the one who came home and cooked dinner every night, and I did that for years and years and years. So sometimes what this all results in are statistics that none of us really would like to have happen to us or acknowledge, but they're there. In a study performed at Hopkins and published in 1997, amongst the faculty at Hopkins, the investigators found that 37%, or a third, of the female physicians on the Hopkins faculty had gone through a divorce. That was in contrast to about a quarter of the male physicians. So why does this happen? Again, probably for the reasons that we've been talking about. I also put a quote here from the internet, medicalspouse.com, stay-at-home dad. So he says, "So, DW, dear wife, is now off on her third conference. The boys and I get to stay home." Actually, that might be wonderful. I might think that was a wonderful thing. She's, quote, roughing it, unquote, in the Colorado mountains. She had to go and get the required CME credits, but please, she's going on a sleigh ride pulled by draft horses to a secluded cabin in the resort, fed a magnificent meal, free drinks, and hot chocolate. How romantic. Well, I can tell you that my experience at CME courses has not exactly been quite like that. But nonetheless, you can understand that it could engender some resentment on the part of the stay-at-home spouse. And finally, at the bottom is an interesting finding, I think, and that relates to two-physician marriages. Are there any two-physician marriages here in the room? That's probably a safe question to ask. Show of hands, two-physician marriages. There you go, we have one. Interestingly, in this study, people or physicians who were in two-physician marriages actually did better. The divorce rate was only about 10%. And contrast that again with the study I showed you at the top, where it was about a third for women and 25% for men. And it seems as if you might expect that in two-physician marriages there would be more conflict associated with two call schedules, running around to multiple different institutions possibly, and someone having to pick the children up from daycare and so on and so forth. But actually, as a general rule, two physicians do better. Now, what about career issues? Well, there is still a compensation gap. There, again, these are not my independent numbers. These come from the literature. Overall, across the United States, there's still about a $20,000 compensation gap between male and female physicians at the same level. In addition to that, and we'll talk more about this later on in the talk, women tend to have fewer role models, or have in the past. 80% of 415 respondents in a survey that was sent out about 5 years ago, this was American College of Physicians, not surgeons, reported no female mentor. In addition, there's a lot of data, and again I'll show you some more of this, that show that women tend to have decreased academic progress, which is related very often to childbearing. Less institutional support, less secretarial support, less research funding, fewer publications, slower self-perceived career progress, and finally overall lower career satisfaction. And really, this may be the most important take-home message here. If you look again across the board, female physicians have a 60% greater odds of reporting burnout compared to male physicians. There was a recent study published in Archives of Surgery regarding alcoholism in female surgeons. How many of you have actually seen this article? Well, when this article came out, and it came out about probably 2 months ago, the day it came out, I got a phone call from my department chair, and he was simply outraged. And what the study shows is, or what was done in the study is, a couple of years ago, the American College of Surgeons sent out a survey which appeared to be a quality of life survey, and they sent it out to all the female members of the American College of Surgeons, and their response rate was about 60%, which is pretty much average for most surveys. And it was a fairly long survey. I will tell you, I filled it out. It had like maybe 50 or 75 questions, but buried within the overall quality of life survey were a number of questions that specifically addressed alcoholism. And when these numbers were tallied and the results were published, it appeared as if 25% of female surgeons actually had a problem with alcohol abuse. And really this caused a tremendous amount of controversy and, of course, negative publicity, right, and negative reactions. Now, my suspicion is that it's possible that the persons that tended to fill out the survey might have been those who had more issues with regard to their quality of life, and so perhaps more problems with this. And I suspect that 25% is a very high number compared to what it really is. However, I will also tell you that across the board, physicians have about the same rate of substance use disorders as the general population, and that's about 10 to 15%. And so, just as a take-home message, remember that we're all susceptible to those things, and look out for it, look out for the warning signs. Also, something really important is that suicide rates in female physicians are actually quite high. And if you look at female physicians compared to other types of female professionals, it's between 4 and 6 times higher, and compared to the general populations, it's almost, again, up to 6 times higher. So if you are a female physician and you are experiencing burnout, please, I encourage you to get help. We'll talk about this a little bit more again later on in the talk. The solutions, education, that's why you're all having to listen to me today. Obviously, child care is a really important part, and part-time positions, and then again, fostering communication. So having explained all of that, I'm now going to offer you a different opinion. And you can think about this. Dr. Karen Sibert is an anesthesiologist. This was published in the New York Times in June of 2011, and really, again, it's one of those things that actually spurred quite a bit of controversy. Her attitude is quite different, and she says medical education is supported by federal and state tax money at the university level. Student tuition doesn't come close to covering the school's cost, and at the teaching hospitals where residents are trained. So if doctors aren't making the full use of their training, taxpayers are losing their investment. With a growing shortage of doctors in America, we can no longer afford to continue training doctors who don't spend their careers in the full-time practice of medicine. It isn't fashionable and certainly isn't politically correct to criticize work-life balance or part-time employment options. How can anyone deny people the right to change their minds about a career path and choose to spend more time with their families? I have great respect for stay-at-home parents, and I think it's fine if journalists or chefs or lawyers choose to work part-time or quit their jobs altogether. But it's different for doctors. Someone needs to take care of the patients. So we'll now move along and talk a little bit about gender discrimination and sexual harassment. A couple of definitions. Gender discrimination refers to comments or actions that intentionally or unintentionally devalue the individual because of his or her sex. Sexual harassment is repeated and unwanted sexual behavior or the creation of a hostile environment. Now, I won't spend a lot of time on that because I think we all get plenty of training in that regard at this point. Again, though, the EEOC recognizes two types of sexual harassment, quid pro quo, and a hostile environment. Quid pro quo is translated as this for that, and it refers to a situation. An example here is a teacher who stipulates that your grade will be based on whether you submit to unwelcome sexual contact. And I'll give you an example of that was published in the American Journal of Radiology. The more common phenomenon, I think, in this day and age is hostile environment. Verbal, physical, or visual forms of harassment that are sexual in nature, sufficiently severe, persistent, or pervasive, and unwelcome. A single severe incident, such as a sexual assault, could create a hostile environment. More commonly, a hostile environment is created by a series of incidents. So here are some examples of hostile environments. These all happen to be things that have actually occurred. I didn't make these up. Male nurse corners female MD in supply room in OR and attempts to kiss her without provocation. And again, I apologize to the men in the audience. Present company is excluded. Male MD repeatedly and without invitation gives shoulder massages to female MD. Male residents discuss sexual attributes of female medical student in front of other students. So that, of course, this happened on my service. The female medical student that overheard this came and complained to me. And finally, this last one is something I got off the internet. Male pediatrician tells young female patient you're developing a nice set of breasts. That's just not acceptable, and probably everyone here knows that in this day and age. Now, here is the quid pro quo example from the American Journal of Radiology, and I realized after I put this on here, you don't have to read all of that, but basically the gist of this story, which is a true story again, is that a female radiology resident was approached by a male radiologist who happened to be the program director for radiology, and the initial comments were things like, you're the prettiest resident the program has ever had, and these 10 kind of migrated on to, you are the sexiest resident that the program has ever had. And then there were periods of time when the female resident would be on call at night and the male radiologist would show up and say that he had to work late. And then he began to tell her stories about how things weren't going well for him at home and his wife wasn't meeting his needs. And eventually the resident brought it to the attention of the department chair. And actually, the way it ended up was the program director, male radiologist, was sent to some courses in sexual harassment training, and he really got better. And the resident was able to continue on in the program. So, happy ending, but not the right thing to do. So, what should you do if you feel you are experiencing sexual harassment as either a man or a woman? Well, what they teach you nowadays is the first thing is you explain firmly to the perpetrator that this behavior is unacceptable and insist that it be stopped immediately. If that doesn't work, the next step is to report it up the chain. But probably the worst thing you can do in this day and age is just to pretend like it didn't happen. Okay, well, I'm done with sexual harassment now. The final thing I'm going to talk to you a little bit about is gender discrimination. This particular part refers to female and male surgeons specifically. And this happens to be from an article that was published in Annals of Surgery last year as well. The senior author on this paper is Omaida Vasquez, who is actually a vascular surgeon. And if you turn your attention to the two lines here, what you're looking at is progression through career on the x-axis, and on the y-axis, the percentage of men versus women surgeons. So in terms of matriculation into medical school now, it's about 50-50. 50% male students, 50% females. By the time you get here into the faculty positions, and somehow they seem to have sort of mixed up associate and assistant, but we'll say at the associate professor level, about 65% of associate professors are men, whereas only about 35% are women. By the time you get to the full tenured professorships, about 75% are men and about 25% are women. And by the time you get to department chairs, again, 90% men, 10% women, and deans, it's even worse. And we'll talk a little bit about some of the possible explanations for this. Overall, in the United States, 28% of general surgery residents currently are female. 15% of attendings are female, and 2.4% of department chairs. So out of 125 academic surgical departments in the United States, there are currently 3 women who are chairs. Those women are Nancy Asher at UT San Francisco, Barbara Bass, who actually was one of my mentors at the Methodist Hospital in Houston, and Julie Freischlag at Hopkins, who has been a mentor to many vascular surgeons. So again, the numbers definitely go down as your career advancement increases. This just shows you something about vascular surgery in the United States. In 2008, where the year, which is the year that these statistics came from, there were about 2,800 board-certified vascular surgeons in the United States, and about 7% of them, or about 135, were women. Now, again, that number has increased significantly from when I started out in vascular surgery over 20 years ago, when there was really only about 3 or 4% women. So it's increasing. Some of the things that are currently inequitable in academic surgery, the average time to promotion is longer for women overall, 6.5 years compared to about 5 years for men. And in terms of being asked to serve in leadership roles, 6% women, 25% men. Women also tend to be paid less, unfortunately, at this point. So overall, about 63 cents on the dollar compared to what men receive. And they also tend to have fewer and smaller NIH grants. Of course, some of the, again, the argument can be made that women are less devoted to their careers than men are, and we'll talk a little bit about that. This quote here at the bottom, again, comes from the same article, and it says 96% of 105 female medical students saw surgery as, quote, unfavorable, unquote, to their gender because of negative attitudes of surgeons, lack of female mentors, male bias, competition, and lifestyle incompatibility. Well, the key here is that half the individuals entering medical school are women. And there is projected to be a great shortage of physicians in the United States as the baby boomers, my generation, get older. So we are going to need more doctors, and we're going to need more surgeons. And so it's imperative that we capture more of that 50% female. So here are some of the explanations for why people say that there are fewer women in senior positions, but it's not a glass ceiling. And we'll go over each of these. The pipeline effect. And basically what the pipeline effect means is that there aren't enough women at junior positions to move through the pipeline and occupy those senior positions. It's also been suggested that women lack the requisite innate leadership skills. I suspect nobody in this room probably thinks that. And that women are less, quote, serious, unquote, about their careers. So what about the pipeline effect? Well, in the Annals of Internal Medicine, this group did a study where they looked only at people who were quite senior across the United States and the American College of Physicians. And so if you look at those who had been in practice 20 to 24 years, so quite senior, about women were full professors 68% of the time, whereas men were full professors 81% of the time, and that was significant with a p-value of less than 0.001. And again, when you look at 25 to 29 years of service, 63% of the women were full professors and 86% of the men. So again, even if you compare those who are senior, have been through the pipeline, and are presumably qualified for the positions, there still tends to be a few more in the male profession. And even in fields such as OBGYN, pediatrics, and psychiatry, which have been traditionally the fields that women have selected, they have captured at least 50% of the positions in residency for the last 25 years. They're still underrepresented in leadership. 20% full professors and 10% department chairs. Now, this happens to be a study that comes from the business literature. So this is not about physicians per se. It's about women business professionals in general. But I chose it because it's a meta-analysis, and so it took a lot of almost 20 other studies and reanalyzed the results. And it's looking at whether women lack leadership skills. And basically, looking at the outcomes, comparing male and female leadership, the study found that women produce significantly better outcomes than men in terms of the extra effort they inspired from subordinates, the satisfaction that people expressed about their leadership, and their overall effectiveness in leading. And again, this comes from the business world, but I would certainly suggest to you that women have equal leadership skills, although our leadership styles do tend to be very different. And then finally, there's the issue of being less serious about your career. Well, what this study does, and again, this was published in the Journal of Surgical Research, this looked at abstracts presented at the Association of Academic Surgery and the Society for University Surgeons from 2002 to 2004. Overall, the authors found that women authored 9% of the abstracts and 11% of the publications. However, if you look at the publication rates based upon the abstracts, the women were more successful than the men in getting their research published. About 70% of the abstracts authored by females were published, and only about 50% of those authored by men. In terms of the impact factor of the journals where these abstracts or publications were published, it was significantly higher for the women at 4.7 compared to the men at 3.4. And what this is trying to tell us is that women who do research, at least using research as a surrogate for overall seriousness about your career, women certainly do seem to be as serious. They are interested in their research, they are publishing in good quality journals, and they're expending the effort to get their abstracts on at SUS and AAS and to produce from that. So what are the barriers that contribute to the glass ceiling? I think that it does exist. Sometimes it's also referred to as the sticky floor. Let me just give you some of my ideas together with some stuff that's published in the literature about what some of the solutions could be. So first of all, in terms of lack of mentors. If you look overall, this is an article from Archives of Surgery in 2000, only 14% of women surgeons had a female mentor. And 56% of those thought that the mentor used the mentee to further the mentor's career more than their own. Again, at that time, and again, this data is a little bit out of date at this point, but only 15% of the women reported a good role model. And again, I think this is changing dramatically. The article at the bottom, 10 women surgical leaders were interviewed. Actually, that included those 3 women who are currently chairs of departments of surgery, and about 40% of them said that they'd had a female mentor in their career. So the message here is that at least in the past, there have not been a sufficient number of female mentors, but of the women who have achieved great degree of success within the surgical field in the United States, more of them had female mentors somewhere along the way. So what about the solutions? Well, first of all, in terms of role strain, in terms of those conflicts of managing your family and your career, there are things that the individual can do, you, as well as the institution. So first of all, for all of you, I encourage to think about when you want to have children. Plan for it. Get it organized in there. So if you really feel that you need to take a year off or do research for a year, you get that organized. Get help at home. Renegotiate the division of responsibilities. Talk to your spouse. Engage them. Get them involved in child care and parenting activities. And finally, something that comes up a lot, I think, is advise women to avoid inequitable shares of assignments that are not rewarded in the tenure process. Something I've seen frequently in my own institution is I've seen committee responsibilities shoveled onto women. Please, again, males in the audience, don't take this the wrong way, but I can certainly tell you that my partner at UTMB was the chair of several committees that involved a lot of work, setting up the whole skip data system, right? You did that. You were also chair of another committee. I can't remember the infection. She was very heavily involved in infection control. And unfortunately, I think sometimes as women we don't know how to say no. And so we take on these responsibilities and, you know, we're pleased to be asked. I'm pleased to be asked. At the same time, when it actually comes to the tenure process, very often they're looking more at your publications than they are at your committee responsibilities. So just think about those things. And what can the institution do? Well, for one thing, schedule meetings at workable times. I think 7:30 on a Monday morning is a very reasonable time for grand rounds. But when I started at the University of Maryland in 1991, grand rounds was at 10 o'clock on Saturday morning. And let's face it, that really doesn't work too well for families. Minimize nighttime call for parents with young children. That's a very reasonable thought, especially if you're a 2-physician family. Or if you're a 2-physician family and you have nighttime call, get your family to help you, your parents, get a nanny. Do some of those things. Something that has been started in the East, and it is present in several large institutions in Boston, although I have not seen it anywhere in Texas, is they actually offer on-site daycare with longer hours. So you bring your children to daycare in the hospital where you work, and if there is no one available to pick them up by 5:30 at night, you can go down, run by and see them, check in on them, but then they can actually have dinner there in the daycare, good food, so on and so forth, and you can pick them up later. And then the other thing, of course, is to create part-time tenure-track positions. There are many women in the fields of pediatrics, psychiatry, who do part-time work. In surgery, it hasn't been really brought into the forefront yet. In fact, I really know no one in the surgical world who is working in a part-time position, and certainly not in a tenure-track position. In terms of gender discrimination, that sort of subtle thing where you are devalued because of your sex. So first of all, on the individual level, leaders need to serve as role models. So my department chair in Galveston, Courtney Townsend, has been very active and visible in terms of promoting women in surgery. We need to publicly acknowledge blind spots to promote openness. So again, you know, that's why you're listening to me this morning. Speak up when confronted with offensive behavior if you're a woman or a man and you feel you're being harassed. Counsel colleagues who display unacceptable behavior and terminate employment if it persists. And finally, appoint committees who take female candidates seriously. In terms of the institution, assure important issues are not conducted in settings where women are generally absent, so don't make the decision about the next committee appointments or the next grant applications when you're out on the golf course, you know, with your colleagues of one particular sex. Establish workshops to sensitize colleagues to gender issues and set standards for behavior. Educate students early on. Now we're seeing a lot of this type of information being presented to medical students, where certainly in my era it wasn't. And then again, set up mechanisms for dealing with inappropriate behavior. Finally, in terms of scarcity of mentors, again, let's appoint more women to leadership positions, and that will lead to more women qualified as mentors. Use visiting professorships to increase female role models. Encourage men to rise to the occasion, and encourage women to rely on multiple mentors. On a personal level, I can tell you that I have really had what I would say are 3 mentors over my career. Jean Strandness was the first. I had Bill Flynn when I was at the University of Maryland, and at UTMB I really had 2, Courtney and a man named Jim Goodwin, who is helped me with my NIH grant. I have never had a female mentor. And all I would suggest to you is that sometimes some possibilities might be that you have multiple mentors for different reasons. So I had Jean Strandness when I was a medical student and a resident, helping me get started in my career. I had Jim Goodwin, who specifically helped me with my NIH grant. And if you cannot find a suitable mentor in your own department, go outside your department. Find one in a different department. I also, something we kind of talked about a little bit last night at Lori's house at our AWS get-together, there are a number of people in the United States, both male and female, who are available to do career coaching or life coaching. And these are individuals whom you pay, and very often the coaching is done over the telephone. Maybe now it could be done over Skype or something like that. And you pay this person a certain amount of money for a period of time, and they are available to coach you with your career or possibly with your life. And I really encourage you, if you have issues that you feel are not being addressed, to consider that. At an institutional level, establish an association of female faculty, and I think most institutions have done that. Recruit mentors from non-medical or other medical departments. And finally, participate in regional or national networks that link mentees and faculty. The Society for Vascular Surgery now has a program whereby if you are a resident or medical student and you would like to have a mentor, you can be linked with one through the internet. And the mentors and mentees are all encouraged to go to the annual meeting and to meet up with one another and establish relationships and then continue those afterwards. So I'd like to thank you very much, and if anyone has comments or questions. Sir.
Hi, that was really, really thorough. I mean, very good.
Thank you.
I have a question about the glass ceiling and the 63 cents on the dollar and specifically money. You say you've never met a part-time surgeon.
I personally have not.
But my question is that based in that diagram with 63 cents on the dollar and the 6 little...
Yeah.
Was that is that based on the same equivalent RVU billing?
Yeah, those are based on full-time positions, equivalent RVUs, and they come from the AAMC.
So a woman bills the same amount of RVUs and gets paid 63 cents on the dollar?
That is correct. Across the United States, right? In academic institutions.
So, Killewich, that was a great talk, very stimulating. I think you laid out why the talk is important to basically stimulate discussion and thought. I tend to be a people optimist, I would say, and I think things have changed in ways that are significant, and they're changing. I'll say there's a woman academic surgeon who, previous president of the Southwestern Surgical Congress, when she was there, she told me, we're going to run the world, don't you? that we're organized, and things are changing, and she is correct, I think. To me, whenever I think about things that create the glass ceiling or lead to it, I would say the most serious problem facing young women surgery today is the blind spot. You talked about the blind spot. So I'll put that some people are comfortable dealing with the people that they normally deal with. This is just how people are. So they don't realize that they're excluding people or doing something because they're just comfortable with the people that they're with. I would say that's probably the most serious problem because it's hard to recognize and doesn't meet those traditional things about gender discrimination. There's the other side of it though, in that I have a son who plays soccer on 2 different teams. The teams are very different. One's a school team, one's a club team. And he told me one time, he said, I feel more comfortable with the other team. And he plays better on the other team. And he participates more on the other team. And so I think there's that blind spot leads to situations. I think if you were to look at participation in national regional meetings of young women surgeons, I think it probably lags like you would show those other things. And I think there's an opportunity, and I've told anyone who will listen to me, both men and young women, that there's an opportunity today that really probably didn't exist 30 years ago, and that every single surgical organization is looking for young surgeons. They're looking for surgeons to continue coming to meetings and organizations, and there's a real opportunity, I think, it's for both men and women, but because, as you know, participation is 75% at least. So I would encourage to let people not let that blind spot keep them from participating. And it's true that some of those meetings may not be, they need to change as well. We've talked about I think most surgical organizations have talked about how do the meetings need to change. But I think there's a real opportunity for particularly young surgeons, young women surgeons, with respect to national leadership positions in surgical organizations. Great talk.
Thank you very much. I agree. Woman in the back. I'm sorry, I don't know your name.
This is very timely. Question. The needs of women surgeons in terms of the mentorship are fairly diverse and certainly need more than one mentor. There's no superhumans, and you need them both inside and outside of the university at the regional and national levels.
I agree.
The question is this. When you're talking about career planning, I'd like to know your thoughts about the necessity for very careful and strategic career planning that really, at the beginning, really traverses 10 years in the future, and that's modified for each 10-year period, as you 5 or 10-year period, and what the says about that and what your personal feelings are and how residents really need to think about strategically planning a career.
So her question is about strategic career planning and planning out 5 to 10 years ahead of time. I mean, the literature certainly supports that that's a good idea. In practice, it's not often it's more difficult to pull that off. But everywhere you go, every research article I've ever read, the 2 times I've been involved in training programs for leadership skills, they all encourage you to think 5 to 10 years ahead of time about where you want to be and to write down your goals and then, develop your plan for how you're going to do that. So yes, I think that's a great idea. I just think that in practice, sometimes things happen that, require changes along the way.
Is that what our male colleagues are doing when they sit down to plan their careers?
Well, yes, I think so. I think that, let's face it, that is a that's advice and an idea that really applies equally to everyone in the room. We should all sit down, think about what we're going to be doing over the next 5 to 10 years and plan it out, and that will lead us to be the most successful. Sir. Oh, then you. And
the population that we draw upon for medicine or law or psychology or any other professional endeavor is a general population. And gender roles are set by the cultural context from which they come. People that are busy looking at these concepts of gender roles now, looking at the millennialists, see a profound difference in the way young women and young men relate to one another compared to the previous generations before them. You see profound differences, for example, in the assets.
I'm sorry, in the what?
In the assets, for example, that their parents have as opposed to what they have. You see a fivefold decrease essentially in the assets held by their parents, by Generation X, for example, and the millennialists. The demographics, we have massive population expansion going on here. So that's what you're drawing from to create the next set of professionals. What I don't see is anybody looking at that. If you look at the entrance class, at the admitted, the matriculated class for medical school, law school, 60% of those people are women. And that's pretty much the case all over the place in higher education and professional education and development now. So I'm really wondering if we're not busy, trying to deconstruct and reconstruct our concepts of our gender roles from the previous generations, and whether or not how much those actually apply to the generation of people that are actually coming in now. And I'm concerned about the fact that nobody's looking at what effect that's actually having. This massive input, as we have a larger population, we have to have more and more physicians, more and more surgeons. What are we doing to look at the attitudes, the gender roles, and the gender and the actual interaction? Since when you look at stereotypic gender roles, they rarely have anything to do with the actual behavior that most people play out in their own lives every day. Sometimes they do, and sometimes they don't. So where is the attention in medicine or surgery to what the population we're actually drawing on now? The profound differences in the way they see each other in terms of gender roles and expectations.
Well, I think you're certainly correct. I mean, I guess one of the big issues that's going on in medicine and in training programs right now, of course, is the changes in people's attitudes with respect to work hours. However, having said that, I will tell you that the Society for Vascular Surgery has started a number of initiatives, just probably in the last 3 to 5 years, specifically attempting to at least recruit young women into the field of vascular surgery because it's been so heavily dominated by men in the past. So there's some stuff going on. May I, go on.
No, I was just going to comment, one of the things I think was very good for me at UTMB that I don't see here is that UTMB had an on-campus daycare.
Yes.
And it did not have very extended hours, but it had people who were willing to help out for additional cash. And so my husband worked an hour and a half away in Houston, and if I had late cases, I had a little girl there, she was one of the daycare workers, she would pick them up and take them home for me. But it was very convenient that it was like 2 blocks off campus. And so if I needed to run and take them to a doctor's appointment or whatnot, I would get a little break in between, I could go do that. It was all right on campus. And that was a very good benefit that I guess it's different here. It's the university hospital, and we were all one down there, but that was a very, very good benefit for our young female faculty.
Sir.
That's a great presentation. My baby sister is a surgeon, and I've heard a lot of these things along the way, but I'm going to say something I hope it's not too offensive.
Go for it.
I know some women who are near the top of their career in high-power professions, and I've heard them complain about these things and salary and equity and so on. So why don't you go to the male dean and confront them with these numbers? Well, I don't want to So I wonder to what extent in the competition for resources, competition for promotion, grants, and so on, that behavioral choices by women, either learned or acquired, affect the outcome, and to what degree that explains some of the figures we see.
Yes, well, you're correct. I mean, and I can't give statistics, but there's certainly plenty of data out there that shows that women tend to also undervalue themselves and not to speak up as often. And so part of the whole education thing is to change the attitudes or the mechanisms of functioning of women in that regard, and also maybe to educate everybody, I guess I would just say that, but you're correct. Well, I thank you very much. Did I do okay?